So thank you very much, Mira, and thank you to the organizers. Thank you to KCMC for having us here. It's an honor to be here and to have this opportunity to be a part of this conference and understand better what the opportunities and challenges are for establishing cancer care here. I'm a medical oncologist. I do have a disclosure. The program says that I'm with the University of Minnesota. Technically, that's not exactly correct. That's my fault for not making that clear. But I did actually graduate from the University of Minnesota Medical School, did my fellowship there, and was on the faculty for several years. I've been a community oncologist for the past 27 years, but I still do have an adjunct faculty position, so I guess it's not entirely wrong. So what I wanted to do today is spend a few minutes talking really about some very practical aspects of what's required to provide medical oncology services. We've heard and discussed a lot about radiation oncology, and appropriately so, and some of the technology involved and the controversies around what technology works best and what's going to be the most efficient and effective to establish here. But another significant component of cancer care, of course, is the delivery of medical oncology services and particularly chemotherapy. We heard a bit about that from Dr. Daugherty, but I wanted to just again outline for you some of the aspects that I think are important for us to be thinking about as we work to establish a full cancer care program. So essential elements: we need personnel, we need chemotherapy agents, we need supportive care measures, and we need management of symptoms and complications of the treatment that we deliver. So to do that, we obviously have to have the providers. We have to have physicians who have oncology training and expertise. We need also, I think, at some point, advanced practice providers, nurse practitioners, PAs, who can help to expand the availability of services. We need the clinical space, of course, exam rooms, a dedicated infusion center, and most particularly trained oncology nurses who can safely administer that therapy and help to monitor the patient's condition and manage their side effects. And of course, we have to have pharmacists and pharmacy technicians who can assist in the provision of the chemotherapy, can provide the added checks and balances to make sure that this is administered safely and without any error. We have to be able to prepare the chemotherapy. This is something that is somewhat complex in the sense that one needs to have a mixing hood that has laminar flow in order to be able to safely prepare the chemotherapy and protect those who are doing that work with an anteroom that works with that laminar flow hood. And then storage and disposal of the chemotherapy agents, the excess or the waste that is generated has to be done in a safe manner as well. So what can we do from a standpoint of chemotherapy? And I would not stand here and pretend to understand all of the challenges and obstacles that might be important to consider in this compared to those of you who are obviously here in the country and doing it. But I thought about this and thought that there is a fair amount that we could accomplish with a relatively limited number of chemotherapy agents. These are the most common cancers that we see here in Africa. And if you then look at what effective treatments we have for those cancers, one can come up with a relatively small list of chemotherapy agents that could be quite effective. And these are all drugs which are now generic and thereby somewhat less expensive than the brand name agents, although there still are substantial challenges to meeting those costs. And Tara Rick's poster over there on the board, I'd invite you to look at again if you haven't, points out the challenges of the cost of many of these therapies relative to the income of the average Tanzanian. There are also oral agents that are effective, tamoxifen for estrogen receptor positive breast cancer. Prednisone is part of the therapy for lymphomas, anastrozole, another hormonal agent for breast cancer, bicalutamide, which is an anti-androgen for prostate cancer, and capecitabine, which is an oral chemotherapy agent, which is now becoming generic, that is effective in both colorectal and breast cancers. And there are some injectable hormonal agents, leuprolide for prostate cancer, and glycerolin and fulvestrant for, again, hormone receptor positive breast cancer. So if you take those agents and the more common cancers that are seen in Tanzania, one can think about how these agents may be used most effectively. So for cervical cancer, if it's locally advanced and being treated with radiation, cisplatin is often combined with that radiation and makes it more effective. More advanced disease may be treated with paclitaxel and cisplatin. Breast cancer, and as I'm learning, in Africa there's a fairly high incidence of triple negative breast cancer. That is breast cancer that does not express estrogen or progesterone receptors or overexpress HER2/neu. So those cancer patients, if they have disease at least confined to the breast and axillary lymph nodes, would be candidates for adjuvant chemotherapy, which can substantially increase the probability of cure, using doxorubicin, cyclophosphamide, and paclitaxel. Kaposi sarcoma, if it is more advanced, doxorubicin, particularly the liposomal formulation, and paclitaxel are effective agents that can be utilized in advanced Kaposi sarcoma. Esophageal cancer, carboplatin and paclitaxel can be used. Regimens have also been used that include cisplatin and 5-FU, which may be becoming less favored because of toxicity. And for prostate cancer, initially at least, hormonal agents are effective and can prolong survival substantially in patients with advanced disease, as well as, in the case of leuprolide, be important as an adjunct to radiation therapy in locally advanced disease. So there are opportunities, I think, to accomplish a fair amount, accomplish a great deal, utilizing a relatively limited panel of agents that would hopefully be available. Now, of course, chemotherapy can be very toxic, and supportive care is a very important part of the therapy, not only for patient benefit in terms of alleviating and preventing side effects and symptoms, but also hopefully maintaining their willingness to come back for ongoing therapy if that's needed. So antiemetics, ondansetron, dexamethasone are highly effective and prevent nausea and vomiting in probably 2/3 of patients with most chemotherapy agents. The white cell growth factors, which are probably not readily available here, due to cost, are becoming available, or soon will be available, in the form of biosimilars, which hopefully will be less costly. That remains to be seen. And red cell growth factors as well, erythropoietins, to help support patients through anemia related to administration of chemotherapy. So, utilizing these agents to address the nausea, vomiting, and diarrhea, which can be side effects of the chemotherapy, the mucositis that can occur with topical agents. Infections and febrile neutropenia are certainly an area of concern, and was interested to hear that in Bugando you have facilities for isolation and protection from infection, which would be important to have, because infectious complications of severe neutropenia from chemotherapy can be life-threatening. And then, of course, bleeding, anemia, thrombocytopenia, blood transfusions, blood product transfusions, red cells, platelets, and if possible or available, erythropoietin certainly can be helpful in avoiding the need for the red cell transfusion. Now, there are, beyond these agents, newer things, and certainly in the last several years, the availability of these agents has been a very exciting part of medical oncology. Targeted therapies, monoclonal antibodies that attack or attach to certain antigens that have an impact on cancer cell growth and replication. Targeted agents which interact with various growth pathways within the cell that also have a significant impact on a number of cancers. But one then must also consider the value proposition. What is the added benefit versus the additional cost of administering these agents? Rituximab is a monoclonal antibody against the CD20 receptor on B cells. does improve remission rate and survival in many situations, many types of non-Hodgkin's lymphomas. Bevacizumab, which blocks the vascular endothelial growth factor, has activity as an adjunct to chemotherapy in a number of situations. There was a very recent report from the GOG in advanced cervical cancer that adding it to chemotherapy increases survival by 3.7 months. Statistically significant difference, but I think one might well argue whether that's a clinically significant difference and whether there is true value in the highly expensive agent when the impact on survival is unfortunately quite limited. Sorafenib is an oral tyrosine kinase inhibitor active in hepatocellular cancer, but really its main effect again has been to improve median survival by a very modest few months compared to not using that agent. And trastuzumab perhaps is not in the same category. That is the agent used to treat breast cancers which overexpress HER2/neu, where there is in the adjuvant setting a substantial reduction in the risk of recurrence. And also it can be very effective in the management of metastatic disease. So again, a very exciting area, lots of new things that are happening there. The advances you can say are certainly limited in their overall clinical impact, and again, as I said, the value proposition has to be considered as to whether these things would be utilized or made available. So, just to summarize briefly, obviously a team of trained professionals is important. As we heard in the last speaker, training the staff is a critical part of developing the Cancer Institute. I think that, as I said, a great deal could be accomplished with a relatively limited number of chemotherapy agents. The newer or more costly agents may be of some potential added benefit, but I think the benefit-cost ratio has to be considered, and we don't want the perfect to be the enemy of the good. And supportive care is critical. Symptom management, management of side effects and complications are critical components of high quality care. And I think also, of course, compliance with treatment and the willingness of patients to continue on a course of therapy that may extend over several months' time. So again, it's my pleasure to be here. Thoroughly enjoyed meeting many people here and have gained a tremendously expanded knowledge and understanding of what the challenges and opportunities are for developing a cancer program here at KCMC. So thank you very much.